I'll introduce you. Thank you everyone today for joining. Today we have Dr. Chika from UT Southwestern, and she's going to be presenting on an introduction to reviewing of portal images. So I'm going to hand over the microphone to her.
Great, thanks Tia. Thanks everyone for joining. As Tia mentioned, my name is Chika Nwachukwu. I'm an assistant professor at UT Southwestern. I see GYN and breast patients. Today I'm just going to go over basics of reviewing a portal image. So as you can imagine, this is a challenging topic to teach because it's one of those things where you learn as you do it, but I will try to cover in today's talk portal imaging and its utility and benefits, the different types of imaging that we have available, different types of error corrections, and what imaging allows us or affords us to do. And then I'll end the presentation with some example cases, and I hope that by the end of this talk, you understand the basics and utility of portal imaging. So feel free to ask me any questions. So you guys have spent a lot of time learning and discussing the benefits of improved treatment technology and of 3D conformal radiation. And really, this can only be realized if the target and normal tissues are given the radiation dose that's been prescribed in the plan. So we know that any differences, whether or not they be small, between the prescribed treatment and the actual dose delivered can essentially compromise or negate the benefits of 3D conformal therapy. So, and essentially what that means is that you have a reduction in tumor control probability and an increase in normal tissue complication, which is exactly what we want to avoid. And this is where imaging comes in handy. So just a little bit of background and historically about port films. They play an absolutely critical role in the quality assurance process. So they're important for an accurate delivery of the radiation beam. They're important for lots of different things, some of which include patient positioning, the block and MLC verification, field matching, gap verification, just to name a few. So historically, film-based portal imaging had been the traditional medium for portal imaging, but as you can imagine, this is time-consuming, labor-intensive, impractical to try to do a port film prior to each treatment. And like film-based imaging is notoriously poor, has notoriously poor quality, especially with photon energies greater than 6 MeV. And so EPIDs essentially, so electronic portal imaging devices have essentially replaced film-based imaging, and most linear accelerators now will come with an EPID system. So the EPIDs use a digital imaging system to create images with improved quality and contrast over the traditional port films. It's a more efficient and more effective method for determining the radiation field placement and accuracy. Again, I mentioned that it's digital, so this means you can acquire multiple images, and we know that this is associated with reduced errors. The EPIDs have a flat panel detector array, and so you have better resolution and faster response essentially. And we know that EPIDs are important for QA, and they provide some dosimetry data as well. Additional imaging tools that we now have been afforded with newer machines and newer technologies are retractable X-ray tubes that are mounted onto the treatment gantry. And with these, you can perform the most common imaging types that you can perform in the MVs, KV, X-rays, and the cone beam CTs, which is what I will focus on today. I note that there are many more other imaging modalities, but today I'm just only going to focus on the most common ones. So the MV ports really we use for MLC checks, really to just a way to look at the beam's eye view of the treatment plan that you've created. The KV imager, essentially, it's called an OBI if you have a variant system. It's called an XVI if you have an Electra system. This is really for isocenter and bony anatomy setup. And then some systems have a KVMV imager. Again, this is for isocenter and bony anatomy setup. And then you have your cone beam CT, which is a volumetric KV imaging system, also used for isocenter, and then helps you to delineate soft tissue anatomy. So I'll go over the three that are most common, as I mentioned in the last slide, the MV ports, the KVs, and the cone beams. But prior to doing that, I just want to talk about the types of errors and what imaging has really helped us to do. So really, errors have been categorized into these two big categories: the machine-related errors, which I'm not going to talk about today because this is not what imaging essentially does for us. And then there are patient setup verification errors and then corrections. Under the patient setup verifications and corrections, there are essentially three types of errors. So there's a systematic error. This is an error that's identical for all of the fractions for that particular patient. For example, if you are treating a pelvis and you scan a patient, you're treating the pelvis and you're treating higher up to the para-aortic nodes, and you scan a patient with the arms on the chest, for example, and the hands happen to be in your treatment field, that's a systematic error because for all of those fractions for that particular patient, you have the hands in the field. There are also random errors where you have daily variations and it's different for each fraction for that particular patient. And then you have intra-fraction deviations where the patient moves during the single fraction. So really the imaging is really going to help us to identify the imaging types that I'm focused on today are really going to help us to identify and fix these systematic and random errors. But really, to be able to do this, to be able to fix any of these errors, you really need a reference image to be created, and that's what you compare to your treatment setup, right? So you either have a digitally reconstructed radiograph or a reference. This is important to compare your treatment setup to. Did I hear a question? No. Okay. So here's the systematic flow, treatment planning flow. So let's just go through this. Let's just go through the process. So you obtain your CT scan during simulation. The oncologist, the clinician, delineates the target volumes, which I know you guys have learned about, the GTV, CTV, and PTV. You also delineate your organs at risk. Once the plan is created and you approve the treatment plan, then a DRR or CT is generated. It's automatically generated upon approval. Important thing to note is that once this DRR is created, you want to have your radiographer or your planner export the contours onto this DRR so that you have it available when you do get to the treatment console. What you export really depends on what areas you're treating. So things to export include fiducial markers, if that will help you with treatment localization, target volumes, things like the carina if you're treating along the lung area. Bony anatomy can also be very helpful. So these things get transferred to your record and verify system. And the most common ones are Mosaic and ARIA. I know that some people also use a Monaco Pinnacle system. And then depending on whether or not your treatment planning system talks to the machine that you have, this also gets transferred to a treatment console. So once at the treatment console, now at this point, you're ready to treat the patient, but we have to introduce in the portal imaging before we treat the patient so that you can either do online correction or offline correction. So what do I mean by these? So your online correction is really the intra-fraction correction. So let's just go through this schematic here. So prior to treating the patient, so this is online correction, you image, you assess the image. If you're okay with it, then you're ready to treat. If you're not okay with it, you make some corrections, and then you re-image, assess, and treat. And you do this prior to every image. So this online correction essentially reduces your random and systematic errors. So we use this for the initial treatment. So before any patient gets treated, we want to use online correction where you're there live at the machine while the portal image is being shot. You make the corrections prior to treatment. We also use this for palliative treatments or treatments where you have just one particular fraction. And then critically important when you get to the point where you're doing SBRT or SRS, you want to use online correction prior to each SRS or SBRT treatment. As you can imagine, these are such high doses that you want to make sure you're not missing your target. Inter-fraction correction or offline correction essentially is when you make the corrections after the patient's been treated. So you image that patient gets treated, You now offline look at the treatment image that was acquired. You assess it. If it's okay, then you can, there are ways to alert the radiographer who's going to treat that you've assessed it and it's okay for them to treat. If it's not okay, then you make some corrections, make some notes that they need to apply prior to treating for the next fraction. So I'll have just a few slides on how we review offline images at the end of the talk. So the inter-fraction, the offline images really decreases the individual systemic errors. So we use this in situations where we're getting either weekly or daily imaging. So like weekly ports for breast, we look at this, or if we're getting daily or weekly cone beam CTs for pelvic or abdominal treatments, or whatever it is where you're getting repeated images, you need to be taking a look at these images so that you're alerting the radiographers when you want some sort of change. So just some general guidelines to keep in mind as we get into the examples for looking at online review. So I mentioned earlier that we do this prior to the first fraction, and then when do you if you have any shifts that are essentially beyond your re-imaging limit, for most places, at least here we use 5 millimeters, most places also use 5 millimeters, then you would re-image prior to treating or prior to the subsequent fraction. And so what do you align to? You want to specify this on your prescription sheet. So when your treatment plan is transferred to the treatment console and you sign your prescription, you want to let the radiographers know, this is what I want you to align to. So when you acquire this portal imaging, I want you to align to either the target, if you can see if your target is radiographically visible. You can align to radiographically visible tissues or organs. You can align to bony landmarks, and you can also align to fiducials if that's available to you. So what should be in your field of view? Really, your entire PTB should be in your field of view. But noting that these can be modified. So sometimes you're treating a really long head and neck area where you're treating, up to the skull base and including the level 4 nodes. And sometimes that whole view isn't able to be fit into your field of view. So in that case, you want to make sure that the most relevant, or at least your high dose regions, are in the treatment field of view. And your most important organs at risk are also in that field of view, so that you ensure that the high dose region is getting the dose that you want it to get, and then you are not you're not under treating the high dose region or over treating an organ at risk that may be close by. For plans that have a single plan with multiple isocenters, for example, if you're going to do a cone beam CT, just remember that you want to do 1 cone beam CT per isocenter. Just some other navigational terms. Again, these are going to differ depending on what imaging modality you have. So in our system, LNG means craniocaudal. In some systems, this is all written out, so you don't have to think about it. Lateral means left to right, vertical means end to post, and then depending on what machines and what treatment machines you have and what modalities those machines are capable of, you can do pitch, yaw, and roll. Okay, so let's get into some examples of MV ports. So essentially what this is you're acquiring images using the radiation beam. So because this is using the same radiation beam that you will use to treat the patient, the geometric configuration is typically very, very similar. So the MV ports do suffer from reduced contrast because they rely on Compton interactions. But what the MV ports are useful for are really to check your MLCs. And really, it's just a beam's eye view of your treatment plan. So essentially, you get the MV ports to see, is this what I had planned on my treatment plan and system? And does it look very similar to what I'm about to treat? So here's an example of a patient who had, this is a late stage patient who has stomach cancer and has metastatic disease, but had significant bleeding. And so we're treating the stomach palliatively in this particular case. And so here's the treatment plan that we've come up with. Here's a treatment plan that we looked at and we felt had covered the stomach adequately, but minimized dose to the normal tissues. And when you look at this, right, so here on this panel is my beam's eye view. I can see my dose coverage to the stomach. I can see how the MLCs relate to this area. And then I can also look on the CT, on the treatment plan in view here, that I know the dome of the liver is close by. I know the heart is close by. So all of these things are things in your mind when you go onto the treatment console to look at what does my MV port look prior to treating this patient. So here's an MV port. So remember I said for each imaging modality, you need some sort of reference imaging. So here's the reference, here's the DRR that was created with my, essentially with my contour outlined as well as my MLCs, right? So on this type of image, I don't need extra structures. I don't need them to necessarily outline the bones, or I don't need them to outline the heart. Like I can visualize, I just need to be able to see that my MLC structure. And so here's the MV port, right? The MV port I mentioned earlier is a poor quality image, but it just needs to be sufficiently good so that you can tell what your field boundaries are and you can describe them anatomically. So remember on the last slide, I was showing that, oh, I know that the dome of the liver is pretty close by. I know the heart is pretty close by. And when I look at the MV port, I can say, okay, yes, I'm in the right field. I'm in the right general vicinity. So then I'm looking, am I treating what I want to be treating? I'm treating the stomach. And in this DRR, you can see the gas bubbles in the stomach down here and up here. And similarly, when I look at my MV port, I'm seeing the gas bubbles. So I know, yes, I'm in the right treatment area. We also have these graticule systems that you can use to essentially count to make sure that your MLCs line up where you want them to line up. So this is the graticule system here. I was mentioning the gas bubble, so you can see the gas bubble right there and gas bubbles right there. And so when I look, I can see that the gas bubble is there and I can see that it's there. So I know I'm in the general vicinity. You can kind of make out the dome of the liver right there, right? The diaphragm / dome of the liver, and you see that same thing on this side. And I know that the heart was right in that picture on the prior slide. And so as I was mentioning, you can use this graticule system to sort of count. So if I go from the isocenter here and I go 1, 2, 3, I know that that's the top edge of my MLC right there. And I can do the same thing here. If I go 1, 2, 3, and that's the top edge of my MLC. So I can do the same thing from side to side. I can count one check mark there. Similar here. And if I did the same thing going inferiorly, if I did the same thing laterally, I would get the same measurements. So with this MV port, I'm pretty confident about what I'm treating because I've used all these other markers to ensure that we're essentially treating the stomach. Here's another example. This is a whole brain MV port. Again, here is your DRR for that patient. Here we flashed the entire, we've created flash in our field, but we still have blocks right here that we can look at when we get the MV port, right? So similarly here, you can look at where my blocks set up. Are my blocks set up in the same general vicinity as in my DRR? And you can kind of make that out here. You can see that here's the orbital bone right there. You can see that that block is right along the orbital bone there. Once you come down in this area, you can see I'm tracking really well in the same area. And then similarly, if you use the graticule to count, you count from either left to right or up to down, you would get the same numbers. And so this makes you feel confident about treating this particular patient. Okay, so here are some examples where we needed to make shifts. So here's the reference DRR again. So this is a patient who had breast cancer, and we're treating the supraclav area as well as tangent fields for the chest wall. This patient's supraclav field is quite large because of her anatomy, But the point I'm trying to make here is that you can see the medial edge of your superclad field is right along the transverse process of the vertebral body. When you look at the lateral edge here, we can see that it's right below the humeral head. And then when we look at this initial film that was acquired prior to treatment, what you see is that the medial edge is now a bit more medial and it's moving into the middle of the trachea right there, right? So you can say, is this a big deal? Is it not a big deal? But we know that posteriorly, the spinal cord is right there, right? So we don't want to overdose the spinal cord. So we know that this is moved a bit medially. And another telltale sign that this is moved a bit medially is when you look at the lateral border, you can see a pretty big separation between the humeral head right there and the lateral border of your superclad field. So we make a shift. Can you guys see this? We make a shift, and now you can see that the medial edge, you see that here is your outline of the trachea here. Here's the outline of your transverse process right there. You see the medial edge has been shifted. You can see the lateral border is right, again, now right underneath. I have to move. Okay, there we go. The lateral border is right underneath the humeral head. So again, you feel a little bit more confident prior to treating this patient. So you can see where the shifts are helpful. Okay, this is that same patient that I was showing you. So we're treating the chest wall in this area. So this is the tangent field. And the thing that I wanted to point out here, so here's a lateral view. You can see our block goes down this way and essentially covers the heart, right? So our heart is blocked out. What you can see is that the rib is right on top of the block. So during treatment, on the initial treatment film, we see that the heart has moved into our field a little bit, and our rib is no longer sitting right on top of our block, so that we know we have to make some corrections, re-image this patient prior to treating. And so that's exactly what we do here. We re-image this patient. So this patient has been treated in the breath hold fashion. We ask the patient to take a deep breath. We use a vision RT for alignment. And here you see that your rib again is right on top of your block. So you feel a bit more confident prior to treating this patient. You know, some people ask the question, why does it matter? It's a breast. In this area out here, right, we don't care how far away it is. What we're worried about in this particular situation is an organ at risk, so the heart. And in the superclad field that I showed you, what we were worried about was the organ at risk, which is the spinal cord. Okay. So that's a just short examples of the MV portal system. So I'm gonna move into the KV imaging system. So most linear accelerators will have a KV X-ray tube mounted, X-ray tube and detector mounted. Essentially, this helps with the KV system, gives you more contrast than the imaging because this relies more on the photoelectric effect. Out of all the imaging platforms or imaging modalities that we use, the KV imaging gives you the least amount of radiation dose. And it's mainly useful for bone setups. Like we use it for other things as well, but the biggest thing that we use it for is for bony setup. The disadvantage, some would argue, is that you cannot visualize your treatment field. And also there's high distortion if you have metallic implants with KV imaging. So here's an example of a patient where we're treating the shoulder area. And so the gray outline is the DRR that was generated after the treatment plan. And the red overlay is the treatment image that was initially acquired. And you can right away see, right, that even though we think we've positioned the patient appropriately, we think that the arm is in the right position, we can see here, looking at the red overlay, that the arm is in a completely different position than where we set her up. So we want to make some shifts and realign this patient to get her to be in the right position. Again, why is this important? For the KV, we can't really see the treatment field. So we're treating in this general area because this patient has metastatic disease in the axilla. But what's in here that's really critical and important, especially given that we're going to a high dose, is the brachial plexus, right? So the brachial plexus tracks down from the neck into the supraclavicular region before it goes down through the axillary area. And so you want to make these shifts, get the arm in the right position, make sure that we're treating the tumor that we're concerned about and not over-treating, under-treating that area or over-treating a normal structure. So KVs are pretty straightforward, again, used mainly for bony anatomy. And so if we move into the cone beam CTs, so again, I mentioned that this is a volumetric, essentially KV imaging. It uses the same system, the X-ray, the KB X-ray tube, essentially. And you scan, what you do is you're scanning either a continuous, partial, or complete gantry rotation around the couch so that you can get an average position of organs with respiratory motion. So the cone beam essentially allows you to get both inter-fraction setup changes and anatomical changes that are related to weight changes or organ filling. For example, when you're treating like bladder, when you're treating in the pelvis and you want a bladder full type treatments, the cone beam allows you to be able to assess that detail. It also allows you to assess whether or not the patient's lost significant amount of weight, where's the rectum in your treatment field, and those sorts of things. So the cone beam CT gives you useful soft tissue resolution. So here's an example of our patient where we're treating the pelvic area. So this is a patient who has cervical cancer, and we're treating her cervix, her uterus, some parts of her vagina, and we're also treating an extended field here because of involvement of nodes. So this is the pre-treatment reference CT that's been pushed onto the treatment console. And you can see internal anatomy on the CT very well, right? You can see the bladder. This is the bladder fill requirement that we have. You can see the uterus very well, the cervix. We have some gold seeds in the cervix here. And you can see these things pretty well on the CT scan. So you have some internal anatomy. But we know that this is an area that has quite a bit of motion. So on our pre-treatment image, this is the cone beam that we've acquired prior to treating this patient. And what you see here is that the bladder is pretty empty. And so what does that mean? Is that our uterus has fallen out of our field, essentially. So the uterus is fallen down onto where the bladder was pushing it up. And so in this particular case, what you have to do is like the live image essentially shows you that there's negligible bladder fill. And so you have to delay this treatment, allow for optimum bladder filling, reproducible position of the uterus and cervix, as well as moving the bowel out of the way prior to treating. So in this particular image, here's your treatment volume here, here's the uterus, your bowel is outside of the field. When the bladder is pretty empty, as you can see in this image, you have some bowel that's now fallen into your field. And then we see this, we allow for optimal bladder filling, we make our adjustments. Here again, you can see that the bladder is pretty full now. Your uterus is back in your treatment field. Your cervix is where you want it to be. You feel a bit more confident about this particular treatment before treating the patient. Here's one more example of the cone beam. So this is a patient who's been treated chest wall radiation and a patient who had breast cancer. And you can look at the setup prior to treatment. So there are different views for looking at this. So this view is looking with the split image view. And this particular portion of it is the reference DRR, and this portion that's a little bit more grainy is your acquired pre-treatment image. And here you can see that the chest wall does not align, right? In your pre-treatment image, you see that some of the lung is now in your treatment field. So this red delineates your treatment field here. You see the lung in that area, but what's clear is that your chest wall is not aligned. And you can see that very well here on the sagittal view. You can see that the chest wall is not aligned. Similarly here, okay? So you make these shifts prior to treatment, and now you can see your chest wall is better aligned. Your lung is no longer in your treatment view. You look in all viewpoints. And it's important, I should mention that it's important to really look at all three treatment viewpoints to make sure that your sup and inf, your ant and post, and your left to right corrections are all in the appropriate position prior to treating. Okay, so I said a lot. These are some of the examples of how portal imaging can help your treatment and can help you be a bit more safe. I'm gonna go on to the next sort of slides that I will show is how do we review offline imaging. Before I do that, okay. So these are slides that I made with a colleague of mine to look over INTER-FRACTIONAL, so offline review in a situation where you're getting repeated scans, so either daily or weekly cone beam or KV or whatever imaging modality you are acquiring. We've done this with the Eclipse system. Now I'm happy to go back and do this with Mosaic if people find this helpful at a later time point. So if you're using Varian's Eclipse system, you essentially click on this Varian system. This is what it pulls up for you. So each person will have their system customized. How do you find offline review? Because now you're no longer directly at the machine. Now you're sitting in the workroom somewhere and you want to look at the images prior to the patient getting treated the next day. So you go to quick links, you go to imaging, and you click offline review. So once you click offline review, this is the default screen that pops up, and each person has to set up their own filters. So this might not be showing that great, but hopefully the next slide will be a little bit better. So hopefully you can see this a little bit better. So you have to set up your filters. So for example, depending on what you want to see here, we've selected patients treated in the last 2 weeks. So once you click on this drop-down menu, Varian has lots of different options. You can click on patients treated yesterday, patients treated, whatever filter you want. And so this is essentially the patients you want to approve, or the images you want to review and approve. You can select the oncologist, and then the most critical thing is to select the imaging types that you want to review. So here it says the SIN, the treatment KV, the treatment MV, and the cone beam CTs. These are the things that we're typically looking at. So you want to make sure these are checked. So you want to check new, reviewed, and then you want to uncheck approved, because if it's approved, you don't want it to pull back up. So spend some time putting in the right filters, and that will help you when you're going to review these things offline. If, for instance, you just want to look at a particular one patient's image and you don't necessarily, this is not your offline review time, you can simply put in, the patient's identifier, whatever identifying system you use at your facility, and click search, and it should pull up that patient. So once you've done that, so again, we asked for patients treated in the last 2 weeks who have either new or reviewed scans that have not been approved. It pulls up this list for us. And I'm blocking out here, just blocking out patient information. So there's this checkbox at the very top. Make sure to click this checkbox, because what it does is once you click this checkbox, it selects all of the patients, and then it brings them in systematically, one after the other. So before we look at some examples of that, I just want to help you to get familiar with the icons in the offline review panel. These might be very similar to you if you use Eclipse. You've seen these panels as well. So your window and level is right there, your dynamic filter. So this has a drop-down menu that allows you to select whatever filter you feel is most appropriate. There's a zoom function, there's a show and hide structure function, distance function. This allows you to match images. There's a split window that I talked about. I showed that in one of the online sessions. This is a move-in window. Some people prefer that. This is to draw or freehand contour if you're teaching or want to make a note for the radiographer. And this is to make an annotation on the slide. So here's an example of an offline, what an offline review situation would look like. So once you've selected this checkbox and you click OK, what it does is it pulls up the first patient. So you want to notice a couple of things. So notice that what it pulls up here is you have abdomen, which is the treatment plan that you're looking at. There's another tab here, which I'll highlight in the next slide, session timeline and a course timeline. But right here, it tells you what sorts of images you're looking at. It tells you that you have two different types of images, that you have a KV, MV setup image, and then you have a cone beam CT. So here's your KV setup image. This is a KV, a lateral KV. For the Eclipse systems, it always pulls it up like this. So in the bottom left is your DRR. And then on the top is the image that was acquired for that particular day. The top is your treatment image, essentially. And so again, as I mentioned earlier during the talk, you've had your planner burn the contours onto your DRR so that they pop up for you when you look at your treatment imaging. And so essentially, again, you can see that whether or not your treatment image looks similar to your DRR. You can see that they're very similar. The bones have been outlined in this particular situation because you're not able to see, your actual target volumes. Here's an MV setup DRR, an anterior field. And so similarly, you can look at the bone structure here. Here's the DRR, here's the treatment field, here's what was actually treated for that particular day. And you can kind of see, am I in the same similar position? Here, I'm looking at the pelvic brim right there, and I see that, yep, that's exactly where I want to be. So this looks like something that would be acceptable for treatment. There are some buttons down here that are important, and I will talk about them in the next slide. So this particular button is a task pad. It's a list of all those patients that you have selected. So if for some reason you want to go in and select a different patient, you can click that button and it will pull up the task pad and you can go to the next patient. These buttons right here allow you to move from image to image. So here it shows you that there's one of two images and you're looking at image one and two of three because you have a KV, an MV setup, and then a cone beam. So if you click on this black button, it moves you over to the cone beam CT. Okay. So I mentioned that, there's a session timeline and a course timeline. And the session timeline, so the two things that you want to make sure that you're looking at the plan that you are evaluating and then the session timeline. These are the most important things. So when we click on this session timeline tab, essentially what pops up is details of that particular session. So here again, you see that there's the right lateral KV setup and anterior MV setup. This particular icon here means that there's a delta icon. It means that there's a shift made prior to acquiring the cone beam CT. So if you see this star button right here, it means that these images were acquired, a shift was made, the delta icon, and then the cone beam CT was acquired, and this is a new image that needs to be reviewed. So once you review your cone beam CT, if you like it, then you can click this check mark. It checks it off that it's been reviewed for that particular patient. So I just want to go over how do you match the anatomy. So in those outlines that I showed you, the pink outline is the film, as I mentioned, that was taken prior to any adjustment, and the blue outline is what you had planned to deliver for the treatment. So the pink outline again is what was planned. The blue outline is what was planned, and the pink outline was what was acquired for that particular day. You can look at those images and you can say, they look pretty good to me. They look pretty similar to me. This I button means that it has been reviewed. Again, I mentioned that if you like the image, you can click the check mark and that says that you've approved that image. So some other things that I had mentioned earlier, you can check your window and level and change your filter level. For breast ports, I usually like to use the dynamic filter, but there's a whole host of things, and you can sort of play with it and see which ones make the most sense for you. You can show and hide structures. So here the cord is delineated, the carina is delineated. So the way to hide any structures that you don't want to see, if they're obscuring your view, you click on the show and hide structure button. You can uncheck these buttons and they will hide all the structures. To match the anatomy, so if you remember earlier, I mentioned that there's a match anatomy here. If you click that button, it sort of overlays the images on, overlays the outlines on one another, so that you can determine whether or not you want to make any sorts of adjustments. So once you click on that button, it says manual auto match, so it overlays the images on top of one another, and you can sort of make adjustments as necessary. There are a couple of views that you can use. So this is the split window view. This is the move-in icon view. Yeah. Oh, prior to go, so this is the split window view. This is the move-in icon view, and then there are toggle views as well. So these are all things that you can use when you're setting up your patient. So when you're reviewing the images offline. Here's an example of what a cone beam would look like if you were getting a cone beam on that patient. Note that, again, there are 3 different views: your transverse, your sagittal, and your frontal view. And again, you want to be looking at all 3. In this particular patient, you see that check mark right here. So we looked at the lateral and AP setups, and we were okay with it. We moved on to the cone beam. So in this particular cone beam here, you see that there are really 3 views, and you can switch between all 3 views, I think, here. So here's the toggle panel that allows you to switch between the 3 views here. The way to know if you're not clear whether or not the cone beam, you're looking at the cone beam or you're looking at the actual reference CT, typically it's pretty clear because the cone beam is not as great as the reference CT, but there's a T, which means acquired versus planned. And then what else did I want to show in here? I think that's pretty much it. You look at all the different areas, ensure that you're matching, and then you can toggle between your cone beam CT and your and this reference CT to make sure that your target is in the appropriate position. And then if you're okay with it, then you can click this check mark to approve it. When do you flag for repositioning or re-imaging? Essentially, remember initially I said if there was 5mm shifts, then I would flag it for the radiographers to re-image and reposition. If there's some sort of patient rotation, that's also something that you would flag. And then the general guidelines, as I previously mentioned. So that was a lot, and I went really fast. So I apologize for talking really fast. I was trying to get everything done within the hour. And I'm happy to take any questions or go back through any slides if anyone would like.
So Chika, we do have one question. What is the advantage of using the offline review, and when is it commonly used? And when you do offline correction, should it be rechecked online?
So very good question. So the offline reviews, really you use them in situations where you're getting multiple images. So if you're getting daily images, so for example, in a patient where you're treating a prostate, for example, some centers will get daily cone beams, some places will get weekly cone beams, or cone beams set on some frequency level. You're not always there at the machine when this is happening. And so you want to be able to review these things offline to alert the radiographers that some certain changes need to be made. Again, I mentioned that you use this really to correct those the individual systematic errors. And so that's really when you use the offline reviews, where you're getting multiple images for that particular patient, and you want to make sure that you don't have significant deviations from treatment to treatment. What was the second part of the question, Tia?
When you do offline correction, should it be rechecked online?
Right. So that's a good question, and I think it's variable. It depends on how well your radiographers, the people who are treating, understand your instructions. If the instructions are pretty straightforward, like say you tell them, shift this patient anteriorly 3 millimeters, that's pretty easy and they can do that. And you don't necessarily need to recheck it if you trust that they're able to do what you want them to do. But if it's a situation where, you know, you're really close to a critical organ, you want to make sure that that critical organ isn't getting an excessive dose, then that's something you might want to check online. The other thing too is, for example, if you're getting multiple images, so if you're getting daily images and you make a correction and you feel like that correction was not implemented, you know, back to back, then that's something you may want to review online as well, to give them a sense of, this is really what I want. This is really the setup that I would like. These are the variations that I feel most comfortable with. And that should help out your planners as well.
Another question is the 5 millimeter action level acceptable for all areas, for example, in postnasal?
So that 5 millimeter shift, I think, is acceptable when you're doing IMRT type plans. If you are doing an SBRT or an SRS type plan, then that's quite a bit. So if you're doing a sinonasal, you mentioned?
Yes, postnasal.
Yeah, so that 5 millimeter mark is that's the limit. So I wouldn't go past that. So it's useful for when you're doing an IMRT plan, for example, where you're gonna have some CTB margin and some PTB margin, right? So your PTB and CTB margin your PTB margin has given you some sort of leeway into how minor shifts may be acceptable, but if you had a major shift, then that wouldn't be acceptable.
Any other questions from anybody?
All right. No other questions, Tia?
It doesn't seem like it. So in this case, I think that we will finish for today.
Okay, that sounds good. Thank you very much for your attention. I appreciate you guys. You have my information. Feel free to reach out to me if you have any questions.
All right. Thank you very much, everyone. And thank you, Nala, for translating.